Welcome back to the second part of our Intro to Anesthesia Pharmacology lecture. In the last lecture, we covered pharmacokinetics, which is what the body does to the drug. Now, we're moving into pharmacodynamics, which is what the drug does to the body. Once the drug gets to its target, what happens next? How does propofol create hypnosis? How does fentanyl create analgesia? How do benzodiazepines produce sedation and amnesia? And how do paralytics produce neuromuscular blockade? This is what pharmacodynamics helps us understand. In anesthesia, this is critical because we are using medications to create very specific physiological effects. We want unconsciousness. We want amnesia. We want analgesia. Sometimes we want immobility, and we want all of that while maintaining patient safety. At the center of pharmacodynamics is the concept of the receptor. We have the drug, it moves to the receptor, and it creates the desired effect. Many anesthetic drugs work by binding to receptors, ion channels, or other molecular targets in the body. When they bind, they change cell behavior, and that creates the clinical effect we see. For example, propofol creates GABA-related sedation. Fentanyl creates mu receptor analgesia, and rocuronium produces neuromuscular blockade. So, when you start learning anesthesia drugs, I do not want you to think of them as a random name on a chart. I want you to ask, where does this drug act? What receptor or target does it affect? And what clinical effect does that produce? That way, you are learning mechanism, not just memorization. Now, let's look at the major ways drugs interact with receptors. We have our agonist, our antagonist, our partial agonist, our inverse agonist, and our allosteric modulator. An agonist binds to a receptor and activates it. It turns the receptor on and produces an effect. A good example is fentanyl acting at opioid receptors to produce analgesia. An antagonist, on the other hand, binds to the receptor but does not activate it. Instead, it blocks the receptor. A classic example is naloxone or Narcan. Naloxone binds to opioid receptors and blocks opioid agonists from continuing to exert their effects. That is why naloxone can reverse opioid-induced respiratory depression. A partial agonist binds to the receptor and activates it, but not to the same maximal degree as a full agonist. A common example is buprenorphine. This means you can get receptor activation and clinical effect, but with a ceiling compared to a full agonist. An inverse agonist is a little more advanced, but the concept is still worth understanding. Instead of simply blocking a receptor, it decreases receptor activity below baseline. You do not need to master every detail of this right now, just know that it is different from an antagonist. And finally, an allosteric modulator binds at a different site on the receptor and changes how that receptor responds. This is very important in anesthesia. For example, benzodiazepines act as positive allosteric modulators at GABA-related receptors, enhancing the inhibitory signaling and producing sedation and anxiolysis. So, the big takeaway here is this. Drugs do not all affect receptors the same way. Some activate, some block, some partially activate, and some modify receptor behavior from a different site. Now, let's move into a very important distinction: potency versus efficacy. Potency is how much drug is needed. Efficacy is the maximum effect possible. So Potency tells you how much drug is required to produce an effect. Efficacy tells you the greatest effect that drug can ultimately produce. A more potent drug is not necessarily better. It simply means less of it is needed to produce a given response. Efficacy is different. That is about the ceiling of what the drug can actually do. So, do not confuse needs less drug with better drug. Potency and efficacy are different concepts, and they are a big concept when you're first beginning your anesthesia school that you do not want to get confused. To understand that more clearly, we use the dose-response relationship. This graph shows how the effect changes as the dose increases. The threshold dose is the minimum amount of drug needed to produce a noticeable effect. So the threshold dose, minimum dose for noticeable effect. Below that point, the effect may be minimal or absent. Above that point, the drug starts producing clinically meaningful action. The ED50 is the dose that produces 50% of the maximal effect in 50% of the population. That is a useful way to compare potency and population-level drug response. The next concept is maximum efficacy. At some point, increasing the dose more does not give additional therapeutic effect. Beyond that point, more drug may simply increase side effects or cause toxicity. And then there is the slope of the dose-response curve. The slope is how sharply effect changes with dose. If the slope is steep, then a small increase in dose can create a large increase in effect. That is very important in anesthesia because some drugs require very careful titration. Another major concept is the therapeutic index. Therapeutic index is essentially the safety margin. This is basically the gap between the therapeutic dose and the toxic dose. A wide therapeutic index means there is a large safety margin. A narrow therapeutic index means there is less room for error. In anesthesia, many of the drugs we use are powerful and require precision. That is why vigilance, monitoring, and good pharmacological understanding are so important. Now, let's bring pharmacokinetics and pharmacodynamics together, and we'll talk about the effect site concentration and the PK/PD relationship. So, plasma concentration does not equal immediate clinical effect. The drug enters the blood, moves to the brain, and causes the desired effect. What matters clinically is not just how much drug is in the blood. What really matters is the concentration at the effect site. The effect site concentration is equal to the drug level at target tissue, which for many anesthetic drugs, the target tissue is the brain. So even if the drug is in the bloodstream, the clinical effect depends on how much of that drug has actually reached the brain and interacted with its receptors. This is where the PK/PD relationship becomes important. Pharmacokinetics gets the drug to the site. Pharmacodynamics explains what happens once it gets there. So one more time, pharmacokinetics gets the drug to the site, and pharmacodynamics determines the effect at that site. One of the most clinically important ideas in anesthesia is that there can be a time delay between the drug being in the bloodstream and the full clinical effect appearing. So a time delay is equal to plasma level changes before the full effect appears. That delay happens because the drug still has to distribute, cross barriers, and reach the receptors at the effect site. This is very important clinically because if you keep giving additional doses too quickly, you may stack the drug before the full effect of the first dose has appeared. That can lead to negative unintended consequences like oversedation, respiratory depression, hemodynamic instability, or deeper effect than you intended. So anesthesia providers are not just thinking about what dose they gave, they are thinking about where the drug is. where it has reached the effect site yet, and whether the full effect has declared itself. This is a much more advanced way of thinking, and it is one of the reasons anesthesia requires so much precision. So, to bring this lecture together, pharmacodynamics is what the drug does to the body. It explains how drugs interact with receptors and how those interactions produce sedation, analgesia, amnesia, and paralysis. We have our agonist, antagonist, partial agonist, and allosteric modulator. It also helps us understand potency, efficacy, dose response curves, therapeutic index, and effect site concentration. In anesthesia, this matters because we are trying to create the right effect in the right patient at the right time and with the right margin of safety. If pharmacokinetics tells us how the drug moves through the body, pharmacodynamics tells us what the drug actually does once it gets to where it needs to go. And when you understand both, you are no longer just memorizing anesthesia drugs. You are comprehending them and one step closer to implementing them in a clinical setting on your journey to becoming a CRNA. All right, that's your foundation of pharmacodynamics. Thank you once again for joining us to continue building your foundational anesthesia concepts. And as always, if you have any questions or need clarification on anything, please leave a comment or send us a message. Thank you.